A transverse fracture of the Olecranon AO classification 21B1 will be fixed with a 6-hole 3.5 1/3 tubular plate applied as a tension band plate. This presentation will show the indications and contraindications, the patient position and approach, the instruments needed, the reduction and fixation of the fracture, and the aftercare of the patient. The indications for tension band plating are distally located Olecranon fractures, or a multifragmentary Olecranon fracture in which the articular surface is intact or can be reconstructed so that it can buttress the posterior plate. The contraindications are if the articular surface fragments do not provide an adequate buttress to protect a tension band plate, for example, multifragmentation of the articular surface, bridge plating may be necessary. Advantages: early active motion, compression of the articular surface. These are the X-rays of a 35-year-old woman who fell while ice skating, sustaining a transverse fracture of the Olecranon AO classification 21B1.3. These are the X-rays taken 6 weeks after the accident. Full weight bearing is allowed. The patient is positioned prone or in lateral decubitus position with the arm on a radiolucent support. The use of a tourniquet is optional. A supine position is also possible, although in this position there is less access for the image intensifier. The incision is started 3 cm proximal from the tip of the Olecranon and curves slightly radially around it, and extends distally 4 to 5 cm. The triceps tendon is identified and split longitudinally down to the Olecranon, and proximally down to the joint surface. The instruments for reduction are the large pointed reduction forceps and the small pointed reduction forceps. To contour the plate, 2 bending irons are needed. The flat-nosed parallel pliers and the wire-bending pliers can also be used. Also required: the 3.5 universal drill guide, the 2.5 mm drill bit, the depth gauge, the 3.5 mm tap with handle, and the small hexagonal screwdriver with holding sleeve. Here is the fractured bone model. The proximal radio-ulnar joint is marked in red. The fracture is reduced with the help of the small pointed reduction forceps. The reduction is held temporarily with 2 K-wires. Make sure that the K-wires are inserted so they do not interfere with the planned position of the plate and the screws. The fracture is additionally compressed as much as possible with the large and the small reduction forceps. It is advisable to drill shallow 2.5 mm holes in the bone model to avoid the tips of the forceps slipping during application. The reduction is controlled with direct visualization and under image intensification. The 1/3 tubular plate must be contoured to fit the proximal ulna. It must be bent around the tip of the Olecranon, through the split of the triceps tendon, and lie as close to the bone as possible. The plate is contoured with 2 bending irons. It may be easier to use the flat-nosed parallel pliers and the wire-bending pliers. The plate should usually be bent to 90 degrees. The contoured plate is positioned on the bone. The first 2.5 mm Cortex screw is inserted through the second proximal plate hole. The drill is aimed toward the opposite side of the radial head and toward the coronoid process. The opposite cortex must be penetrated to achieve the required stability. The depth is measured. The screw hole is tapped with the 3.5mm tap. The screw is inserted. The tip of the screw should protrude at the opposite cortex by 1 to 2 mm. The second screw is inserted through the most proximal hole. This screw crosses the first screw but is aimed toward the radial side to penetrate the opposite cortex. Be sure not to protrude into the proximal radio-ulnar joint, which is marked red. The third screw is inserted in the most distal plate hole to fix the plate to the Olecranon shaft. With a simple transverse fracture, the screw can be inserted in the eccentric position to achieve more compression across the fracture. The osteosynthesis is completed by inserting screws in the remaining distal plate holes. The K-wires and the forceps are now removed. As this plate works as a tension band plate, it is mandatory to fix the small proximal fragment and the triceps tendon with a circular suture to the third plate hole or around the head of one of the screws. These are the X-rays of the plastic model. Note that if the fracture line is more distal, longer screws should be used. Active assisted motion is encouraged within the first few days, including gravity-assisted elbow flexion and extension. The patient should be encouraged to move the elbow actively in flexion and passively in extension, pronation, and supination as soon as possible. Any loading of the elbow over 3 kilograms should be avoided for 6 weeks. This presentation has shown the indications and contraindications, the patient position and approach, the instruments needed, the reduction and fixation of the fracture, and the aftercare of the patient.